Hi, everyone. Thank you so much for attending our webinar today. We're just going to wait another few seconds to let everyone come in from the waiting room. Okay, we're going to get started. Again, thank you everyone for attending. My name is Judy. I'm the Executive Director of F.E.A.S.T. And today's topic is supporting an adult child in treatment, which is a topic that a lot of parents are dealing with. And we are thrilled to have Rachel here with us today to talk about this topic. I want to start with a few housekeeping rules. So the first thing is please shut off your cameras and please keep your microphones off through the entire duration of the webinar. And if you have a question, you can just stick it in the chat box. We're going to take questions at the end. And I just ask that you don't put a comment in the chat box because it's really hard for me. I moderate the questions at the end of the webinar. And if there's a lot of kind of chat between you members of the webinar, it's really hard for me to find the questions in there. So I'm going to ask again, please shut off your cameras, shut off your microphones, utilize the chat box to ask questions, and we're going to get started. Rachel, it's all yours.
Oh, sounds good. Let me just share my screen. Okay. Let's see. Okie dokie. Well, I'm happy to be here today. So I'm just going to introduce myself before I get into all of this. So my name is Rachel Shagnon. I am a licensed marriage and family therapist at UC San Diego Health Eating Disorder Center for Treatment and Research. I am a senior clinical program specialist here, a part of the management team. I do oversee our multifamily programming in our adult program, as well as co-lead some of our radically open DBT groups and self-compassion groups. And I just pop into other groups throughout the day. So happy to be here talking about this topic. So I plan to just give an overview of, what we're going to be talking about over the next 45 minutes or so. I really want to discuss just the importance of supports and parents being involved in treatment, regardless of the age of your child. It is really vital that you are a part of this process, whether that be, showing up to sessions or just being present in their lives as they're going through this process. We'll talk a little bit about that. We'll talk about some evidence-based treatments for adults. It is important when seeking out treatment to seek out evidence-based modalities and to make sure that providers that you are researching specialize in the care of eating disorders. I would say be wary of providers that say that they treat eating disorders but don't necessarily have formal training with this population. So we'll discuss some of those key modalities to look for when you're looking for a provider. There are several ways that you can support your loved ones. It can be really intimidating to know how to approach adults. Society tells us that once they are 18, they are adults and they are on their own. However, we know that they're still developing, especially as young adults, and perhaps might even be behind in development if they have had a longstanding history of their eating disorder or treatment history. So everybody needs support to some degree while they're going through this process. So we'll discuss some of those ways that you can provide support. Also, it can be intimidating to know how to be involved or how involved you are allowed to be and what that looks like. So we'll talk about that. And then even though they are adults, contingency management, behavioral reinforcement, and extinction is important. So I will give just some overview of that. And then also just some basic skills that you can also utilize when you are supporting your loved ones. I know not all of you are able to be a part of their treatment, given they get to decide who is a part of their treatment once they hit 18. So I'll just give some ways you can be involved even from afar, even if you're not a part of the actual formal treatment. So let's get into it. So, importance of family and support involvement. So I want to emphasize that even if you have tried family therapy before, or if you have found it unhelpful, it is important and it's recommended that you try again. If your child had any sort of physical ailment, heart disease, cancer, whatever it might be, you wouldn't just stand and not engage in some sort of treatment that they are doing. Eating disorders are just as important. They affect individuals physically, mentally, emotionally, and there are so many aspects of this that are important to be involved in and paying attention to. So it's not just for children and adolescents. This can continue once they hit adulthood and are in adult programs and seeking out their own treatment. Um, Individuals with eating disorders often have significant ambivalence about recovery. So structure is going to be key. Um, Something that people don't necessarily recognize are the ways that eating disorders affect individuals neurobiologically. So I always like to teach parents this term. It kind of helps to give some insight into how they can be supportive and why. So, I know probably all of you are dealing with a varying degrees of eating disorder diagnoses, whether that be anorexia, bulimia, RFID, what have you. But just take this that anorexia is an egosyntonic disorder. So, what that means is this is limiting a patient's insight into the harm of their behaviors. So, patients with anorexia typically value their disorder and lack ability to create their own structure. On the other hand, bulimia is by and large an ego dystonic disorder, meaning the behaviors such as binging, purging, they conflict with the patient's values. Those people also still require structure and support to maintain recovery. So, just something to keep in mind. Well, that insight kind of lacks, whether it be egosyntonic or a dystonic disorder, and structure nonetheless is going to be important. This is especially important in young adults. Um, and given the ambivalence, I do want to note that the level of involvement from supports and caregivers, this might differ, and that's totally okay. So we'll discuss that in a few slides of, how you might be able to be involved based on what your child is like, quote unquote, allowing. So when we're working with eating disorders, we are focusing closely on the prefrontal cortex of the brain, which serves as the control center and is responsible for things like concentration, planning, decision making, insight, judgment, and all these things are impacted by eating disorders. So when things are going well, the prefrontal cortex, which is located right here, acts as the control center that keeps our baser emotions and impulses in check. So as this part of the brain develops, support and guidance is needed, especially because supports and caregivers, you might be able to be the ones who are aware of noticing that declining mental health and physical health and emotions prior to your loved one being aware. You have such a different perspective on their illness than they do. So when we are thinking about this and of involvement, our main focus is engagement in just some way, shape, or form. So it can be a problem when parents or supports of adults are not involved, especially for young adults, but adults nonetheless, because if an adult leaves treatment, we have no recourse as providers to, if we haven't established contact with parents and supports to get them back in here. So something else to keep in mind is that a lot of patients live with their families while they're going through this process. I know not all of them, and a lot of them do. And so any work that we are doing as therapists and providers might be ineffective if those changes aren't also consistently being made at home and structure is being monitored at home. So importance this is so important to be involved, and I cannot stress that enough. And again, that can be via therapy or via other skills, which I'll talk about later on. So some more information on just why this is important comes to you. I mean, you as parents and supports also require support. I do love this quote on that second bullet point from the Journal of Eating Disorders and how it mentions that including supports not only benefits the patients, but it also the support carers in their role. So while doing family therapy with adult patients is often different than we might see it for children and adolescents, because it's not uncommon for individual and family therapists to be the same provider for an adult. We as providers, I'm speaking for myself, need to build rapport with the support person. And I want to make sure when I'm working with parents that they know that they are being heard as well. You, as parents and caregivers, are having an experience of your loved one's eating disorder, and we need to make sure that we're acknowledging your experience in order to help you ground to be as effective as you can be in assisting in this recovery process. So that's definitely not lost on me as a provider. There's a lot of stress put on caregivers, excuse me, supporting those with eating disorders, because you are the ones noticing that declining mental health. This does take a toll on you as well. It's not just taking a toll on your loved one. Obviously, it's in a different way, and that's still important for us to pay attention to. So, studies also have indicated that parental self-efficacy is linked with reduction in a child's eating disorder symptoms like comorbid depression, anxiety symptoms, things like that. So our efforts to maintain and improve parent well-being are not only helpful for all of you, but also for your adult child's recovery. So I like to, remind parents it's okay if you're seeking out your own therapy throughout this process, as well as attending support groups like, coming to F.E.A.S.T and attending things like this. Okay, so I want to talk about some evidence-based treatment options when we are looking for treatment for eating disorders. So I know that everyone in this webinar is here and has varying levels of how long you've been doing this and timelines and experience in supporting your loved ones. But for those of you who might be a little bit newer to this process, or even maybe are just coming back into this process, I want to give some examples of what you might be looking for. So when you are seeking out treatment options for your loved one, these are some of the modalities you'll want to see if a program or therapist offers. This list by no means is exhaustive, and I just wanted to give you a few ideas. So these are the focuses of our treatment at UCSD Eating Disorder Center. So first of it being DBT, so dialectical behavioral therapy. That's my main modality that I utilize when working with adult patients. We know that people with eating disorders do struggle with emotion regulation or the ability to successfully manage their emotions in flexible and effective ways. So some people with eating disorders are highly sensitive to emotion and experience their feelings very intensely, which is overwhelming and often leads to ineffective or destructive behaviors, such as eating disorder behaviors or self-harm or substance use. So many patients with eating disorders have something called alexithymia, which is difficulty identifying, labeling, or expressing emotion. And folks with eating disorders also tend to be prone to anxiety and depression. So for these reasons, dialectical behavioral therapy, an evidence-based treatment, is considered kind of like the gold standard for treating emotion regulation problems and can be helpful in the treatment of eating disorders. CBTE, so this is enhanced cognitive behavioral therapy. So this is basically just CBT for eating disorders. This is one of the most effective treatments for eating disorders. It is a transdiagnostic treatment for all forms of eating disorders. So anorexia, bulimia, binge eating disorder. We can also use it for ARFID. And so there's different stages within CBTE. So stage 1 focuses on gaining mutual understanding of those challenges with eating and gives providers the opportunity to give personalized education to the patient in addressing their concerns. Stages 2 and 3 focus on processes that are maintaining the person's eating disorder. And stage 4 then shifts to the future and dealing with setbacks and how do we maintain that progress. CBT was actually the very first modality I learned when I was introduced to treating eating disorders. So I have found it very helpful in my work. Acceptance and commitment therapy. This operates on the philosophy that negative emotions and experiences are a natural part of life. So it teaches patients to accept the parts of their life that they tend to avoid. And this might be avoidance via eating disorder behaviors. And this modality often is often adjunctive, in addition to other methodologies. So things like DBT or CBT. And then I have radically open DBT here, which is a transdiagnostic treatment which targets a spectrum of disorders characterized by inhibitory control or over control. So this means like maladaptive self-control to the extent that can lead to chronic mental health challenges. Self-control is the ability to inhibit those competing urges, impulses, behaviors, or desires and delay gratification in order to pursue future goals. So this does give an original perspective regarding the etiology and treatment of anorexia via the biosocial model that accounts for temperament, family and environment, perceptual, self-control tendencies, and this is also used for bulimia nervosa as well. So these are some of the things you might want to look for to see if someone has on their website, if they are trained in these things. All of these things can be very helpful in the treatment of eating disorders, and this could be for individual therapy or family therapy as well. So if you are looking, look for these things. And again, not an exhaustive list, but just to give you an idea. Here's some ideas for family therapy. So I know I hear a lot from parents and caregivers of adult patients like, am I still allowed to be doing FBT? I've, been doing this since my child was in a pediatric program or an adolescent, and that's what we were trained in, and that's what we were taught. So yes, you can still engage with some of the FBT family-based treatment stages. I would say, though, that for the most part, when we're working with adults, we're focusing on phases like 2 to 3. We're kind of jumping over phase 1. So phase 1 for adolescents and pediatrics is focusing on that weight restoration piece and presenting that like non-blaming stance regarding the etiology of anorexia or bulimia, and does separate the illness from the client, which we're still doing in stages 2 and 3, but we're not going to be focusing as much on you taking control of the weight restoration piece. And that's just mostly given the stage of life that they are at and what our goals as providers are going to be in helping them to launch, to be able to take care of themselves for the most part moving forward. So in phase 2, we're kind of looking at allowing the client like having their own gradual control over eating. And then phase 3, like addressing that the developmental issues and fostering that autonomy. So we're kind of looking at that when we're working with adults. I would say this is more so something that we look at more when we're working with young adults is when we're including pieces of FBT, and it's not uncommon. Again, based on like how long someone's been in treatment, how long they've had their eating disorder. So there are adaptations made through FBT for young adults and FBT for transitional age youth. So someone aged like 18 to 24 ish. And so what the differences are is in these modalities that it's more so for young adults, providers are giving them the option of who they want to involve in treatment, whether that be parents, whether that be an aunt or uncle, a partner, whoever it might be, because as they are able to choose who they are involving, we get a little bit more buy-in from them. So we are kind of focusing on the fact that if weight restoration is not happening, though, we might need to involve parents a little bit more thoroughly. So, just something to keep in mind. TBTS, so temperament based therapy with supports, and young adult TBTS. This addresses eating behavior from a framework of temperament and neurobiology. So, when you're doing this, you receive psychoeducation on temperament, neurobiology, there's experiential activities focused on explaining the neurobiology and building effective relationships between you and your loved ones, skills training, dietary support, things like that. Um, DBT, which I already talked about a little bit, but the general skills focusing on distress tolerance, emotion regulation, interpersonal effectiveness. And this can be helpful. There's DBT for families, and this can be helpful to know what maintaining factors are in the family and how they can support change. So there are a lot of interventions used in DBT for families that help make that behavior change. It also discusses like behavioral reinforcement strategies, things like that. We incorporate some of these things into couples therapy as well in our clinic, as well as parts of systemic family therapy, which is focusing um, on the system at large. And then you might also learn strategies of like parent management training, which is something that you would probably see more in a pediatric or adolescent program. Um, and this is sometimes helpful in the treatment of young adults when we are looking at principles of behavior modification. So we try when we're doing family therapy with adults, try and give them the option of who they want to involve, get some of that buy-in from them, and try and say, who, if your parents are not going to be involved, who is going to be involved in your treatment. So again, some of these are might be things you might want to look for when you're seeking out family treatment. Okay. Another question I get a lot is how involved are you like allowed to be in your loved one's treatment? So the level of parental and support involvement is going to vary from patient to patient. I wish that I could say a more direct answer. It's a little bit vague, but variability and involvement is going to consider a few different factors. So, this might be, how much are they allowing based on, them being 18 plus years old? They get to choose who's involved in their treatment if someone's involved in their treatment. I've definitely worked with 18-year-olds that are like, I'm 18 now, I'm not going to sign a release for my parents. Um, and I kind of have to work with them on getting their buy-in for family therapy. So it does depend on if your loved one allows you to be involved. And that doesn't mean that you can't do strategies at home, which, like I said, we'll talk about towards the end of the presentation. The level of ability to participate in recovery that the patient displays. So this is looking like working on weight restoration goals, goals related to reducing eating disorder behaviors, emotional maturity, and their overall ability to engage appropriately and effective outside of program. So it's important to keep in mind that eating disorder recovery is not only about weight restoration and reduction in eating disorder behaviors, but also that emotional maturity, and able to appropriately engage in life on their own. I mean, eating disorder behaviors serve some sort of function that is keeping them from engaging effectively in life. So there's a lot of different factors we want to take into account here. And then to what degree can you, as a support person, be involved? So emotionally, mentally, physically in your loved one's treatment. So parental and support capacity is very important for us to pay attention to. So how often, how much, how willing are you able to give to this process? When we're going through treatment for eating disorders, consistency is key. And we need to make sure that we are holding that to a high standard. So if you are unable to provide perhaps as much as your loved one needs, we may need to go another route and see, what are different ways we can get you involved if it's not necessarily showing up every single week to a session, or are there other people that we can involve? I've definitely worked with parents and partners who just have jobs that are emotionally draining on their own, or their other child is going through something and they can't necessarily be as present as they would want to be. So that's also going to play a factor in how involved uh, you are. Um, and then lastly, kind of like how reliant on you is your loved one. So different factors financially, physically, emotionally. I will say oftentimes we see patients who present with, a desire for a lot of independence. And other times we see patients who have these desires to remain dependent on their caregivers. They don't want to grow up. This is really, really scary. The goal for us is to find the balance between that independence and interdependence. So ideally, we're helping patients to learn to apply and utilize skills effectively on their own while their treatment team and caregivers stand by to provide that additional assistance and support should they require it. So, depending on how reliant on you your loved one is, we may be able to use that to your benefit as a parent and support person. So you have leverage, and we'll talk about kind of that contingency management and how that can be applied. So all this to say, levels of involvement are going to vary. And so as we are doing these like initial sessions with your loved ones, we're getting to know them. We are also trying to figure out where are the holes that we can bring you in. And hopefully we get their buy-in too on allowing you to be a part of their treatment. Um, I do want to say just ways that you can support them in this, whether this might be if you are allowed to be involved in their formal treatment or not. So I'll just give some examples on the next couple slides. So even if you are not allowed to be in the sessions, these are still ways that you could show up for your loved one. So types of support, we have emotional support and then that informational and technical support. So emotional support, being aware, being present, providing validation and encouragement, offering that listening ear. We just usually want to be heard and don't necessarily want that problem solving. And so often I know parents are like, I just want to solve the problem. I don't want to see them in pain. And my first piece of advice is just lead with listening. 'Cause that's most of the time what I hear from my patients that they want. And then that tends to get their buy-in to that problem solving piece later. So just being present and offering that listening ear, taking a non-judgmental stance, and thinking of the eating disorder as separate from your loved one. They didn't cause this. You did not cause this. And I always like to think about like if this is their brain, here's the eating disorder. It's like an octopus that's sitting on their brain and it's kind of controlling them. And so what we're trying to do is come together as a team. Me as the provider, you as the support person, the patient, we are all on a team to fight against that eating disorder. So thinking about it as separate. And then informational and technical support. So how often are they meeting with providers? What are their recovery goals and guidelines? Provide that accountability to them. Providing financial aid, whether that be for treatment, for groceries, for rides to treatment, making sure that they are getting to the appointments they need to, and offering to take them to those appointments and sessions and program if they are at higher level of care. So in DBT, like I said, that's my main modality. We have three different states of mind. So emotion mind, reasonable mind, and wise mind is the synthesis of those two. And emotional support and informational support are ways to kind of represent that emotion mind and reasonable mind. Um, Both are very important for the success of a patient. So we want to make sure we're finding balance between the two. Here's just an image on different ways that you can provide that emotional and informational and technical support. Just some bullet points. So, providing validation, empathy, encouragement, active listening, taking that non judgmental stance, allowing the patient to be the expert on their recovery. That's a really big one that I need to emphasize to parents a lot, that yes, you have your experience of their eating disorder. It is very important we're paying attention to that. And they ultimately are the ones going through this process, and we want to kind of tap into that wisdom. Um, that this is their process, this is their recovery, and we are here just as support people to lift them up and help them move forward. Allow independence when appropriate. I know that can be really scary. Um, Thinking of the eating disorder as separate, like I said, and then verbalizing progress witness. This can be a tricky one. A lot of patients of mine are like, I don't really want my progress to be noticed. I don't really want to talk about it because then that means I'm losing my eating disorder. Verbalizing progress witness could really just be, I know this is really hard for you, and I see that you keep showing up, and that's awesome. And just saying things like that. Or, I have noticed a change in you, that it's easier to talk to you, and I really appreciate that. So even if it's not things like the physical progress that we are noticing. Um and then more so on that informational and technical support side, being aware of recovery guidelines, um, progress rules, non-negotiables, and this might be that you're implementing or their treatment team is, providing that structure and accountability, helping with building and upholding behavioral contracts or agreements, establishing warning signs and being aware of when to step in, and then providing that practical support, like money for groceries, rides, treatment, things like that. Okay, so some different ways that you can be involved in this is again going to vary based on how much your loved one is letting you physically be involved. But these are things that you can do even if you are not necessarily formally involved in their treatment. So, um, providing emotional support. So, again, just being that listening ear, validating, being non judgmental, just being present. Attending support and informational groups. So, coming to events like this, webinars via Feast. I know Feast offers some support groups. I know there's a ton of great resources on their website, of things that you can read in different videos. Um, Sometimes, the treatment center that your loved one is at might be offering support groups. I know at UCSD, I lead a group for caregivers. Patients are not present, and it's just a space for them to talk. We teach them skills. They also have an opportunity just to talk with one another and get ideas from one another. Um, so it's really helpful to be just involved in those types of groups, and you kind of learn how to speak the language of the patients, of like the skills that they are learning. Oftentimes I know in my group we'll review like validation strategies, just ways to respond to certain statements. And like I said, it can be just really helpful to have that space with other caregivers going through this process. Um, Monitoring physical progress, such as weight restoration and meal plan compliance goals. Um, and this might be something that you've talked about with the treatment team. This also might be something that you are just keeping eyes on, and you're providing collateral to the treatment providers. As far as collateral goes, um, providing it to us as providers is so helpful. I love getting the different perspective from parents that I work with. I like to typically touch base with the parents within the first couple of weeks of me starting to work with someone. It just helps me to understand, what maybe I was missing in my first couple sessions, or what I wasn't told by the patient. So you can provide, observations with food, emotional, social, physical changes over time that may have been related to the eating disorder, personality traits. It's really helpful if I know kind of what they were like as a child and adolescent, and maybe how they've changed into adulthood, if they have changed. And kind of what maybe has gone on in their life. Have there been these significant events that have happened, trauma, things like that? Or maybe even things that your loved one maybe you would guess like wouldn't tell me. I know I've definitely like learned about substance use from parents before that I didn't hear from the patient. So anything that you can give us is really, really helpful. And I kind of, when I'm talking to parents, just say, tell me anything. And so often parents are like, I don't know what you want to know. And then they are able to fill an entire 30 minutes or an hour on the phone with me. And so really providing any information that you might have is important, and any treatment history also. Some other ways to be involved. So releases of information give the providers permission to provide information to whomever the patient designates. So oftentimes, providers will ask patients to sign ROIs for previous providers, so therapists, dietitians, psychiatrists, primary care providers. And I always ask patients to sign an ROI for their parents the first time I meet with them. Um, if they say I'm not going to sign one for my parents, I kind of just simply ask them, well, who is going to be involved in your treatment if it's not your parents? As to kind of like not really give them the option to not have any external involvement, my little sneaky way. And I will also try and give them the option to have them sign a limited ROI. So what that means is, um, they're only allowing certain things. So they might say, hey, look, like you can only talk to my parents if I'm present. Excuse me, let me take a sip of water. Or if you talk to my parents, you're only allowed to give them information on XYZ. This can kind of serve as a foot in the door approach, and it's a nice way to get an adult patient's buy-in to allowing supports. Um, So that is something that I might do. And that's something even that like parents have offered up as, ways that they can be involved as well. Of like, hey, like, what if you only signed a limited ROI for Rachel to talk to me? Um, Sometimes patients will say, like, I don't want my parents to know what my weight is, but they can know if I went up or down this week. So different things like that. Um, there might be instances where your loved one does not consent to your involvement in treatment. And that means I cannot necessarily reach out to you. It would be illegal for me to. That does not mean it's illegal for you to reach out to me and give me some ideas. I've definitely gotten emails from parents with information and I can't respond. I can't talk to them, but it's still helpful nonetheless that I have learned the information, or information was left on my voicemail or whatever it might be. So something to keep in mind. You can still provide that collateral even if you're not necessarily speaking physically to the provider. Attending family therapy. So studies have indicated that just one family therapy session can benefit a patient's recovery. So it might also just be a foot in the door if we do one family therapy session. I've definitely had patients be closed-minded, but once we do that initial session, they become more open. Creating a safety net. So this is kind of like spotting your loved one. So we want to help them do things on their own while providing that necessary support so that they don't fall. So what we're doing here is kind of taking inventory of like, what are the things that they are doing well? Are they able to plate meals, complete meals without help? Because if they are, we want to encourage more of that. We don't want to fragilize them. We want to empower them. Alternatively, if they are not doing those things well, they're not displaying the ability to go grocery shopping, feed themselves, this is where we might want to step in. Um, and we could be doing, that spotting or safety net with meal planning, grocery shopping, plating meals and snacks, providing accountability before, during, and after, things like that. There's many different ways that we can utilize that safety net. And then behavioral contracts, sometimes called behavioral agreements or contingency management. I've used an array of different words based on what the patient feels comfortable with. And we'll talk about this in a couple slides, but these can be formal and like designed with a treatment provider, or can be more informal and discussed amongst the family. Okay. Want to give some ideas just on some introductory skills. So I know not all of you are going to be able to be involved in the formal treatment with your loved one. And these are some things that you can just do at home, even if you are not a part of sessions or able to talk to providers. So I always like to teach these initial skills like validation and taking a non-judgmental stance. These are both DBT skills um, pretty early on. So most individuals just want to be heard. I know I mentioned that earlier. So I cannot tell you how often I teach parents and supports about the importance of balancing that validation and problem solving. Um, Most of us, I will say, especially young adults who are more like adolescents, are going to just like turn off the moment they hear an ounce of problem solving. So, what we want to do is we want to lead with that validation. And if we do that, that oftentimes can lead to more openness down the line to be open to hearing problem solving. So there are different ways that we can do this. So there's 6 levels of validation, and I have them bullet pointed here. So just paying attention, listening, and observing. So this means like put your phone to the side, don't multitask. We are sitting, we are present, we are not distracted. We are just here and we're listening. Second level is reflecting back what we hear. So, I'm hearing that you are having a really hard time with XYZ. That must be really hard. Avoiding judgment, just reflecting back what we hear. Mind reading, so being sensitive to what is not being said by the other person. So this might be, they had a really hard, morning. Let's say they went to school, they had an exam, and then they had a therapy session that day. They also had to meet with their dietitian. They're not talking about that, but wow, you must be exhausted. This has been a really long day for you, full of a lot of different things. So being just sensitive to what's not being said. Understanding by looking for how the other person feels and is thinking, what they're saying based on, history. Like I can understand that given all of the things that have happened recently or in your life, like that this would be stressful as well. Um, Acknowledging the valid and show that you see their thoughts, feelings, and actions as valid. When it says acknowledge the valid, so often patients will come in with like I've gained weight, I'm fat, I'm so ugly. That's not what we are validating. What we're going to try and validate in that statement is the emotion that we hear and being sensitive to what's not being heard. We don't want to validate the invalid. So being sensitive to that, and rather than saying like you're not fat, like no, you're not ugly, being, you know, I can understand that this is really frustrating to you. It is really challenging to go through change. I can understand that. Um, Even if we don't agree with what they are expressing a lot of the times, and it doesn't necessarily feel valid or doesn't make sense to us, what we can connect with oftentimes is the emotion. We know what feeling that emotion feels like. And that's kind of what like to tell parents, like, go to that, go to the piece of it that makes sense to you. You know what it's like to be sad. You know what it's like to be frustrated, lead with that. Um, and then taking a non, oh, and then taking, just being, showing equality, not one upping the other person or treating them as fragile. They are adults, they are capable, and we want to make sure they know that. Taking that non judgmental stance. So, approaching their recovery without judgment. So, state what you see, being curious, asking questions rather than applying judgment and making assumptions. So, I always tell parents be curious. Curiosity is key. Ask questions rather than making assumptions. You can describe observations with factual language rather than judgmental language. So a should statement is a very often judgmental statement. Um, so Judgments can be expressed verbally and non-verbally and have negative impacts on relationships. So we want to make sure that we are, just saying what we see and not judging, because that often leads to that shutdown and someone's not open to the support. Validation and non-judgmental stance just fosters that improved communication. So ways to practice taking a non-judgmental stance can be rephrasing judgmental language to facts. So rather than like, you're being so difficult, you can say like, I noticed you haven't started your meal yet. Um, you can rephrase in terms of consequence. So rather than you shouldn't get upset over your meal, you can say, when I see you struggle to start, I feel uncertain and nervous in how to support you in that moment. Rephrasing in terms of preference. So rather than saying it's sensitive if you do not realize the impact of you not eating has on the family, you can say something like, I would prefer if you ate with the family. Thus, we can help support you. So, I statements are key, and then stating in that term of preference. And you can certainly find DBT handouts on this online. And then monitoring your child who doesn't live at home. So, doing family sessions via telehealth. This is not something I did as much up until COVID. And if one thing came out of COVID, it was introducing me to Zoom and how to do family sessions from afar. So it was a game changer. And I would say most of the time I'm doing that with adult patients anyway. Like, very rarely do I have parents and caregivers coming in person for sessions. And that might just be because they're, living on their own or they live elsewhere. Regular check-ins with your loved ones. This can be, and their treatment team. This can be challenging, however helpful. So the check-in can serve as that emotional support, accountability, behavioral containment. Sometimes having phone call schedules helps the patient to think twice about what they're going to do, and gives them that moment to kind of stop, take a step back before engaging in behaviors, because they're like, am I going to want to tell my mom that later, or whoever it might be. And it can be helpful to come up with kind of like a list of questions that you rotate through. And I sometimes will include my patients in coming up with these questions their parents are going to ask, so that it doesn't come as a surprise, and maybe we can work through some of the wording. Um, let's see. Visiting frequently. I'm not going to touch on contingency because that's my last slide. That's the next one. But visiting frequently if feasible. I've also had this be part of contingency management. So for instance, if a patient is not displaying the ability to care for themselves, their support person will come and be with them for maybe even just like a weekend or a few days at a time. And so that's something that I've implemented as well. Ensuring technical support and accountability is taken care of. So making a plan ahead of time. So, it can be helpful just to make sure that we know, when are they getting weighed? Where are they getting weighed? How is it at their dietary office, primary care, um, via a clear step scale? Is their meal plan being monitored by a registered dietitian in sessions or on the recovery record app? Knowing if you're going to be notified if there's weight changes. And then again, this is all going to depend on the varying levels of involvement that the patient allows. However, you can utilize contingencies to leverage involvement, which I'll discuss in the next slide. I can do some questions. Okay, so what if your adult child is not compliant with treatment? So contingency management, behavioral contracts, agreements, whatever we want to call it. And this can be done via formal behavioral contracts and agreements. So we might prioritize the 2 to 3 most important goals. So weight restoration, meal plan compliance, behavioral containment. Like for instance, right now I have a patient on a behavioral contract, and what it's targeting is her weight, and she has to eat a certain percentage of her meal plan every single day. Then we convert these goals and items into concrete rules and expectations. So, okay, you have 3 meals and 3 snacks per day. You have to eat X% at every single meal and snack. And we can kind of do like a point system where they earn things. She also has to make weight progress Monday to Monday. Why we do it a week at a time is because it kind of allows for a trend rather than just kind of going like Monday to Wednesday, like when we weigh our patients. It's a really short amount of time. So we want to see a bigger picture. And kind of saying like, you need to be gaining, she's supposed to gain like 1 pound per week right now, 1 to 2 pounds per week. And if she's eating X%, she should be able to do that. And then creating clear consequences and rewards. So access to phone, car, spending time with friends, ability to be away at college or not. That's a really, really big one with a lot of our young adults. Um, and you can also kind of come up with the treatment provider, what might be some of the rewards and consequences that they're also implementing if it's at a higher level of care. So my patients can earn extra session time or step out of a group or whatever it might be. Um, Informal contingency management. So like, is your loved one allowed to eat with their friends or do they need to eat with you? Do they have access to car keys and their bike if they didn't eat breakfast? Um, are, they allowed to go out with, friends over the weekend or do they have to stay home? So these are all things we want to keep in mind. Um, if your loved one is financially responsible, reliant, excuse me, on you, I want to emphasize you have leverage and you can utilize that. I know a lot of parents are afraid to do that, but you can. And then I just want to say my last couple bullet points. So all of us are influenced by consequences, also known as rewards of our behaviors. So positive consequence is adding something rewarding. This is the most stable way to increase a wanted behavior. And negative reinforcement is the removal of anything negative, as to increase the likelihood of the behavior. So for adults, I often am like, if you do the thing, you're going to get your parents off your back. And that is kind of like that negative reinforcer, because we're taking away like the parents nagging. And this helps to shape behaviors over time. Punishment, I will say is the least effective way usually to change a behavior, as behavior usually only stops in the face of punishment, like a traffic ticket. We're only really slowing down if we see the police officer. That's very common. And so we want to make sure that we are saying like, if you do X, like you can get Y, and trying to frame it in positive reinforcement or negative reinforcement. This is really challenging. Follow through is key. Do not name a reward or consequence that you are not willing to or able to follow through on. They will pick up on that. So that consistency is key. And for every single slide that I showed, I just want to say like having patience with yourself and with your loved one just takes time and practice. So I know that this was a lot and just a brief snapshot, but that is all I have. So we can do just some question and answer in our last few minutes, Judy.
Thank you so much. There are a lot of questions. I'm just going to choose a few that we'll have time for. So I think a few people were confused because you said that you jumped to stage 2 of FBT when you're doing it with an adult. And people are really confused about that. And so am I, quite honestly, because if a person isn't weight restored, how do you skip and they're not able to eat independently? How do you skip stage 1? Or do you skip stage 1? And did we all misunderstand you?
That's such a great question. And I think something that I didn't really mention is when we are doing that with a young adult, I like to give the power back to the young adult in that they are kind of monitoring that weight restoration piece of it with their treatment team. So when we're involving the parents, your piece of it is not the weight restoration piece. Your piece of it is helping with the developmental part of it in that phase 2 and 3. And you are upholding those recovery agreements. You are maybe um, sitting with them, but they are also deciding where they need that support. With a young adult, you might be doing more phase 1, but I would say be more involved in the phase 2 and phase 3, if that makes sense.
So it's not that phase 1 is being skipped per se, it's that it's more in the hands of the treatment team than it would be theoretically with an adolescent.
Exactly. Yeah. Yeah. So rather than putting you as the responsible person for the weight restoration, they're responsible for doing that restoration on their own and with the assistance of their treatment team, because ultimately they're going to be the ones that are having to monitor that moving forward.
Okay. Thank you. That was very helpful. Okay, so so many parents have questions, and I so feel the questions because it's such a hard situation. One of the questions was, how do you create consequences for an adult who's independent? And another one was, how do we position leverage rather than How do we position leverage as a positive reinforcement rather than punishment? And I look at those two questions and they resonate with me personally, but they resonate with so much of what I see on our forums and in our support groups because it's so hard. So I'd like to hear from you. What do you do? Meaning, if you have that leverage that's obvious, then you use it. But if your child is financially independent, if they don't live near you, and if you want to use positive reinforcement, and yet you're met with this wall of resistance, I mean, it sounds great, but how do you actually do it?
That's a great question. So I'll touch on the independent piece first, because this is definitely something that I have worked with. Um, with when someone's more financially independent, emotionally independent, they're doing life on their own, it can be really, really challenging to determine how you're going to be involved. So, I have definitely worked with adults who are, in their 30s plus who are in this position. And unfortunately, their parents have come to maybe the impasse of like, I'm not sure how involved I can be in your life until you are doing the things that you need to do. I'm not emotionally available for you anymore. I cannot do this. That can be really, really challenging. So leveraging kind of what your relationship looks like with them, even if that doesn't necessarily mean cutting the adult off, because I don't necessarily think that that can be helpful, but to what degree are you going to be involved in their life? How present are you going to be? I've also had parents be like, well, I'm just going to then continue to show up and come visit you. And that's how it is going to be. And that can kind of be that, again, that negative reinforcer. If you don't want that, you can do the things that you need to do. But a lot of times what I see is parents leveraging their relationship, which can be really, really challenging. And again, don't say it or do it or say that you're going to do it if you can't follow through on that. Um, if you are met with that wall of resistance, and how do you kind of frame it as a positive reinforcer? I've had parents who, you know, young adults are glued to their phone and they love their phone. And so I've had parents say, like, you get to earn your phone. You get to earn that time, or you get to earn having your car keys. I pay for your car. So I will be the one holding your car keys. If you do X, then I will give you your car keys. And it kind of forms it as like they get to earn certain things rather than things being taken away. This doesn't mean that it's easy or that it's not challenging, especially because it is a huge shift in the, parental stance as well as, what that person is used to. Um, and it can be a huge motivator. I've definitely had patients say like, well, if I'm never going to have my phone, I'm just going to always eat. And there's going to be natural consequences sometimes. If, they're not doing the things they need to do, if they are met with that resistance and the patient's still not doing it, that does sometimes mean that higher level of care is necessary. And that's just sometimes just that natural consequence that comes along with it.
Thank you. We have time for one last question. And it's one that I encountered personally. Your child's an adult and you are allowed and encouraged, as you said, to speak to the treatment team about things that you're seeing at home, things that concern you, behaviors that you're seeing, and you really want the treatment team to know about. When somebody approaches a treatment team of adults, when a parent approaches them, does the treatment team turn around and say to the kid, hi, your mom just sent me an email? Because that really undermines us as parents because we're genuinely concerned. And, our kid sometimes is blocking us from being able to be in contact with their treatment team. And we need to be able to at least communicate one-sidedly. But if we know that the treatment team is just going to turn around and say to our child, by the way, your parents sent me an email, then we're very discouraged. So is there like a standard practice? What can parents expect when they send an email or when they call their child's provider?
Such a great question. And obviously, I can't speak for every single provider. This is actually something that I've run into very, very recently in our clinic, especially because I do have contact with a lot of parents via my carer support group, and maybe they don't have contact with their child's therapist. And so I'm kind of the receiver of a lot of things. But I've definitely had this with my own patients as well. I personally will say for myself, I don't tend to tell them that I heard from their parent or that, this is something that I learned because I don't want to undermine you and I want to make sure because that also might make them ice me out if I'm learning something. And so I tend to try and just kind of use that questioning and use my knowledge to guide my questions with the patient. And we've definitely had it be where, that is part of the contingency management. So like if you are doing XYZ, I'm going to tell them and they're going to know. And that's something that like even maybe I wasn't a part of that discussion that the parent and child did that, but I don't usually like to tell the patient. And again, that's just speaking for myself. I just use it to guide my questioning.
Well, thank you. Unfortunately, we are out of time. This was really a phenomenal webinar. I think we could have gone on for another hour with questions.
I think so too.
And I'm sorry that we didn't have time for more questions, but I really appreciate your time, Rachel, and all the amazing information that you gave us. Feast runs on donations from our community. So if you like this webinar, if you participate in our educational programming, and you'd like to give a donation, please go to our website and do so. We really appreciate it. And I just want to encourage everyone to attend our next webinar, which is going to be on February 12th. How to stay on course in recovery while transitioning between levels of care. Also another really critical topic. Parents really struggle, and I really hope you'll join us next month. So Rachel, again, thank you so much for an amazing webinar. You guys were an amazingly engaged audience. Thank you so much for participating, and I hope to see you again next month.
Thank you so much, Judy, and thank you, everyone.